Dear colleague, dear resident, and young neurosurgeon, it's a pleasure for me to be here. Thank you to be present. My talk is about spine, upper cervical spine trauma. As you know, the craniovertebral junction is a complex and also ligamentous region that incorporates the occiput and C1 and C2 portion of the spine. It's a transition zone between the cranium and mobile cervical spine that permits significant motion, that balance maximum stability and protection of vital neurovascular anatomy with ample mobility and range of motion. Full characterization with injuries require an accurate history, physical examination, and good comprehension of radiographic projection of the craniocervical junction. The educational objectives are to classify the upper cervical spine trauma, to describe the radiographic criteria of instability, and describe the most accepted classification for the different type of craniovertebral junction trauma. Referring to the classification, we adopt the following plan. First, we see the isolated ligamentous injuries after isolated bone fracture, and we finish with ligamentous and bony injuries. The first is atlanto-occipital dislocation. It's the most severe type of injury of the craniovertebral junction. It's found in 10% of all fatal cervical injuries and represents more than 30% of motor vehicle accidents in fatal cases. They are usually caused by high-velocity accidents, and children are often exposed. The mechanism can be hyperextension, hyperflexion, or lateral flexion. 70% of cases can be accompanied by brain and spinal cord injury and severe neurological deficit. They are highly unstable, compress, and distort the spinal cord. The delay in surgery treatment can cause a significant increase in neurological defect up to development of a fatal. Variety plane radiographic measurement technique may use to detect dislocation of a craniovertebral junction. This method assesses the relationship between the skull base and cervical spine on lateral radiograph. These methods are WFNS line, the power lines ratio, the basio-dental interval, and Dublin's method. This method can be applied to find instability of atlanto-occipital dislocation. The WFNS lines extend caudally along the posterior surface of the clavus. This line should be tangential to the posterior type of the dents, and if the occiput is displaced anteriorly, the line will intersect the dents, and if the occiput is detracted or displaced posteriorly, the line will be separate from the type of the dents. Traditionally, this technique has been used to assess basilar invagination, but can provide a general assessment for dislocation. The second measurement is power ratio assess. The relationship of two lines is the distance between the basin and the posterior arc of C1, and between the opposition and the anterior arc of C1. In normal individual, basic average is 1.77, and a ratio more than 1 is fairly reliable diagnostic indicator of anterior dislocation. The third is the Woolley-Bayesian dance method measurement. It measures the interval between the Bayesian and the type of the dent in the neutral position. In adults, the distance average 9 mm, but varies considerably, and any motion between these landmarks on dynamic radiography is abnormal. A distance more than 15 mm in adults or 12 mm in children is abnormal. The last one is the Dublin method, which measures the distance from the posterior cortex of the ramus of the mandible to the anterior portion of C1 and C2. The second ligamentous injury is the transverse ligamentous disruption. This lesion is an instable injury. Mechanism can be a hyperflexion. The diagnosis can be made on easily lateral view and can show a translation between C1 and C2 over more than 3 mm in adults and 5 mm in children. The MRI imaging show a high signal intensity which confirm anterior ligament transverse disruption, and the CT imaging confirm a fracture of the tubercle of C1, which means instability. We talk about it in the fracture of atlas. The first isolated bone fracture is the condyle, occipital condyle fracture. They are only seen with high energy mechanism. They occur with axial trauma. They are almost always unilateral on 19%. The diagnosis is based on CT imaging with reconstruction view to establish the occipital condyle fracture. MRI is recommended to assess the integrity of the cranocervical ligament for determining the stability of occipital condyle fracture. Usually, open mouth radiographs have low sensibility. The most widely classification known for this lesion is Anderson and Montesano classification, which entails a gradation of increased severity. It goes to type 1 to 3, and this classification is has been more recently modified by the classification of Choli, but the two previous classifications are mainly academic interests, as they contribute marginally to clinical decision-making process. There is a New York classification system by Mueller, which is more useful in the treatment algorithm of this lesion. Now, this is the algorithm with according Mueller classification with surgery indication in the type 3. The second isolated bone fracture is atlas fracture. As you know, atlas or C1 is an integral and crucial part of craniovertebral junction and acts as transitional structure between occipital and cervical spine. C1 fracture accounts for 25% of all craniovertebral junction trauma. They occur as a result of motor vehicle accident in 85% of time. C1 fractures are most often a result of an axial load plus an additional vector of compressive force, and they are associated with 40% to 44% of C1 fracture. The cervical spine X-ray remains the first line diagnosis tools to identify isolated atlas fracture. The management of this fracture is based on the integrity of the transverse ligament that can be accessed indirectly with several radiological measurements. The sum of lateral mass displacement of C1 over C2 more than 7 mm in open mouth X-ray mean transverse ligament probably damaged. This is the rule of Spence. A measurement over this number denotes a rupture of the ligament transverse and accessory stabilization ligamentous. MRI is a more sensitive indicator of ligament transverse integrity or distribution than the rule of Spence. CT is always necessary to evaluate the integrity of the atlas rings and to classify fracture between stable or an unstable burst fracture. Concerning the classification, the Jefferson classification relates the mechanism of injury with the type of fracture, whereas the Dickman classification focuses on integrity of the transverse ligamentous and degree of dislocation of the bony avulsion fragment from the lateral mass, which is important to define surgical treatment option. However, Buehler classification, because it integrates categories of previous classification, is far more useful for treatment decision. This is the algorithm for atlas fracture according to Buehler classification. As you see, the type 3B is surgery is recommended for this type. Now the odontoid fracture. They are the most common fracture of the axis. Most fractures present without neurological deficit due to the ample anteroposterior diameter of the cervical spine canal. They are diagnosed based by location of the fracture line, which is most easily visualized on coronal CT reconstruction. The common asset system of classification was developed by Anderson and D'Alonso in 1974, which include 3 types, and the type 2 is the most commonly. In this type 2, the fracture occurs at the junction of the odontoid process with the body. In 2005, Rowers proposed a modified classification system of odontal fracture to help head in fracture management, and the system modified and redefined Anderson and D'Alonso type 2 and 3 odontoid fracture subtypes. According to this classification, which adapt Anderson and D'Alonso classification, the type 2B and 2C are indicated for surgery. Now the Engman fracture is the bilateral of axis sparse interarticular fracture, who was first described by Anton in 1816. Most traumatic Engman fracture are a result of fall or motor vehicle accident, and the injury mechanism typically involve an hyperextension and compression insult. Only 9% were associated with fracture of atlas, and additional 9% were associated with fracture of subaxial spine. Diagnosis of Engman fracture. In the diagnosis, radiographic plans are useful in studying alignment, but are far less sensitive than the CT imaging. For evaluation of the fracture. According to the classification, FND and base classification is based on its array and clinical cause, and this classification has been modified by Levin based on the mechanism of injury. This is the FND classification, and here modified by Levin and Edouard. And this algorithm with for the Engman fracture, according to Levin, FND and Levin, with surgery indicated in the type 2. So there is a technical problem with the slide. Okay, the last type of lesion is a combination atlas and axis fracture. They are relatively common, and they account for 44% of all C1 fracture and 16% of all C2 fracture. The rate of neurological injury are superior to isolated CN or C1 or C2 fracture. The rate of non-operative fracture is superior in C1 or C1 and C2 or C2 fracture. The diagnosis need combination plain radiography, CT imaging, and also MRI finding. The classification of Digman. According to this classification, surgery strategy can be made with surgery for the type 3, which are instable. And for finish, some recommendation. Cervical CT with sagittal and coronal reconstruction plays an essential role in diagnosis and surgical planning of as first-line study. MRI is crucial to assess the integrity of craniocervical ligament, like transverse ligament. Allovenous immobilization is associated with increased morbidity, especially in older patients, and surgery is indicated in unstable fracture. For surgery, the ligament fracture, living 2A and living type 3 require postural surgery or anterior or posterior surgery, and when there is C2 or C3 disc herniation, anterior surgery is recommended. Also, for failure and intolerance to external alveolar immobilization and established non-union associated with instability are recommended for surgery. Thank you for your attention. The next speaker is Amir. Subaxial cervical spine trauma.
All right. Good morning, ladies and gentlemen. This is going to be a presentation in English. My French is very, very bad, so I'll not embarrass myself. Do we have a list of who's in this room? Professor Haidara, do we have a list of the participants? A list? Do we have a list? Where is it? Because there's some people that are starting to fall asleep and are on WhatsApp. So the easiest way to make sure that you stay awake is I'm going to ask you questions. Okay, fine. So let's just go on. We are running late. We'll just get on with the talk. Thank you. So this was going to be given to you by Professor Salman Sharif, who, as you know, was not able to be here due to having COVID. We're just very thankful that he's well. So the educational objectives for this, the first thing is we will start looking at locked facet joints. We will look at how we're able to easily see those on just plain radiographs. There is somebody here that just showed me a picture that he got on WhatsApp. And then we will look at how essentially to bring those facets back. So both open and closed ways to do that. We will touch on basic classification systems for subaxial injuries. We will then move on to burst fractures and what those look like and how those are essentially managed. We will look at a slide on various clinical syndromes that are associated with these injuries. Then the last thing will be sort of management algorithms for how these injuries are dealt with. So this is essentially the various parts of this presentation, and we will go through all of these. Let's just start off with what locked facets are. Now, if you just look at my fingers, we've all seen tiles on roofs, okay? Well, that's not going to help, but I have some names, so that's good. Good. So tiles on a roof. We have one tile that sits essentially above the other. That's how our facet joints look. Now, as there's a flexion injury, the upper one, or the inferior articular process, slides up. It'll reach a top where it will perch, and then it'll drop down, where it's essentially going to lock. I've seen many residents interchange a perch from a lock. Those are two very different things. So it slides up, it'll perch, and then it'll lock. If you've got a flexion with a rotation, one of them will slide up, perch, and lock. That's a unifacet dislocation. If there's no rotation, but one has a severe flexion, then they both slide up. They both perch like a bird, and then they fall down and lock. Okay? Good. And if we look at sort of plain radiographs, and all of us should really be able to make that diagnosis on a plain radiograph. You often don't need to have CT and certainly not an MR to sort of make this kind of diagnosis. So let's just start off with simple ABCs. A, just look for the alignment there. And here we see sorry, the mouse is very small, or the cursor, but here we come in and then there's a step here. So clearly there's an issue with the alignment there. The next thing, B, is, we now look at bones. In a normal lateral cervical spine radiograph, the two facet joints are in line. So you will only see one. But as it jumps, you start seeing two, and that's this sort of bow tie sign that has essentially been alluded to here. We see this joint here, and with an eye of faith, very faint on this, there's another one sitting here. So this is a unifacet at this point, okay? Just moving on. So if one does do a CT scan, now there on the bottom right, there's an image there, and what is called a naked facet sign. That sounds rather rude, but the easier thing is, think of a hamburger. We all eat them. The first thing that I saw when I came to the airport was a huge Burger King. So you guys clearly like burgers. So think of your two buns. You have bread, you have a patty, and then you have a bread on the bottom. And if that bun does not look like a burger and has now jumped to look like this, it's an upside down hamburger. And that's essentially what we look at when those facets jump like that. Okay, the MRs are great, but they're great at looking at soft tissue. Okay, now when it comes to managing these, really we need to get on to reducing them as fast as possible. Do we need an MRI when these patients come in? Yes, no. Not straight away. There is no benefit. It wastes time and it's expensive. The other thing with MRs is that you may just miss a little annular tear and you think that disc is fine, but the moment you reduce them, you have a piece of disc that flies out through that tear and is now pressing on the cord. So essentially your post-reduction MR, which you will not do because of cost, things have changed. So the first thing is you put them in cones, and I think we all essentially have cones and we can do that, and get them into traction, okay? Now, when it comes to weight, we read in all our books, people work in pounds. I don't, and I find pounds very hard to work in. Okay, do you work in pounds?
We work in kilograms.
Coffee. Who's coffee? Okay, coffee is gone. But we work in kilograms. 5, 10, 15, 20. Every 10 minutes. It's easy. It works. Some of the nuances. So for patients that come in with a bilateral facet dislocation, just raise their swan necks up. Start to essentially apply traction with them in slight flexion. That just helps your facet joints get up. They perch. As soon as they're perched, so the birds are just sitting on the top, you bring them into a little bit of extension and drop down that weight. Those facets, in up to 90% of cases, within 3 days you should be able to reduce like that. Okay. Now, what happens in a case where your patient is not awake? Many of these patients might come in with a head injury as well. So he's not awake. You're not sure, do I put traction on this guy? If I do put traction, is he going to get worse? Those are patients that you need to go into theatre and sort of operate on. So what are some of the techniques that we can use whilst doing an open reduction for these? So most of these patients you're going to be operating on from the front. Release that disc, release that annulus. Okay. Issues with coming in from the back is you often will not be able to get to that disc that's herniated out. You've got a bigger cut, it's deeper, higher sources of infection. I mean, they end up, and with one motion segment that sort of slipped, you end up having to fuse 3 vertebrae if you come from the back, vis-a-vis 2 if one is coming in from the front. Okay, so try and come in from the front as much as possible. This is a simple technique of doing an open reduction. So that's a Cloward interbody racer. But really the nuance here is not the word but what is done. So once you've cleared out that disc, look at the inferior end plate or the inferior part of the body of the superior vertebra that's involved. Try and line up your interbody spacer parallel to that, and try and keep it in as deep as possible. So we heard from that great lecture on biomechanics this morning. You want as much of a surface area to try and push on. If it's too short or it's too small and you try and distract that body, what do you think is going to happen? Your names are hard. It's essentially just going to fracture, and that's not what you want. Okay, so you distract that body, you take your lateral radiographs, you wait for the bird to perch, and the moment it's perched, you then push that retractor back to try and get your facets to come down, and that's what these images here are showing you. Okay, what if one doesn't have an interbody retractor system? Your simple Gaspar pins will work well. The nuance here is you do not put in your Gaspar pins straight. Okay? Why? Joel, because I know your name. What is wrong with putting in pins that are straight? So think about this. Sorry?
Posterior distraction.
Yeah. Not just that, but if you put in pins that are straight, and now you go and put in your Gaspar retractor, you will close the back. You don't want to close the back. You want to open up the back. So if you put in your pins that converge, once you straighten them, they will open up the back for you. You then open up your Gaspar retractor. You take your Mark 1 right index finger. You push down on that body, and you bring down your Gaspars, and you will reduce this fracture. Okay? If there needs to be a little bit of rotation, if it's a unifaceted dislocation, one of the important nuances that I learned the hard way at 2 a.m. is when you look at a vertebral body, it's never straight. It's always got a little bit of a curve to it. Always try and put your Gaspars and at the very tip of the curve, in the middle of the body. What that will do is you'll be able to see if there's a rotational issue here. So if it's a unifaceted dislocation, there is going to be a rotation. So once your Gaspars are there, you know that you need to sort of lift it out and bring them into line to help you bring those facet joints back. Let's just look at mechanisms of trauma and essentially how they're now classified. This is an early sort of classification. This is the modified Alan Ferguson, where he looked at the major loading forces, the first being obviously flexion, there was extension, and then forces that were in a neutral position, so sort of straight down, the man that dived into the sandbar. And then the forces that act alone, so whether they're unilateral or bilateral facet dislocations, that's if it's going to be a flexion. If it's going to be an extension, then all that force is going on to the posterior element. So that's where you start getting fractures of your lamina and your facets. If there's a compression with flexion injury, think about what happens to the vertebral bodies. They then start getting cracked, so they break. If there's a distraction, the counterforce would be a distraction. You tear the posterior ligaments at the back. So you crash down in the front and you tear things at the back. A very similar thing will happen if you sort of extend. You crunch down on the back and you tear the ALL and the disc in the front. Okay, so it's all sort of relative to forces. Here we're just looking at these pictorial images of a compression flexion injury, starting from the A, which essentially you've just got a wedge compression here, and as that gets worse, you then get a little crack here. So there's this anterior-inferior breaking of that body there. As the forces grow, you get a teardrop fracture, and then you go into this really bad area. The issue here is that your teardrop often gets kept back by your ALL, and the major part of the body then gets pushed back And that's when the cord starts really being damaged. Okay? And then there's little nuances like this one is up to 3 millimeters, this one's up to beyond 3, but that's neither here nor there. This is distractive flexion injuries. Again, what are we seeing? So in an A, this is sort of very, very mild. This is where you just sort of get sprains and patients will come in with sort of neck pain, but they're stable. As the flexion is a little more, unifaceted dislocation here, bifaceted dislocation here, and then you've got this sort of anterior listhesis, so up to about less than 50%, and then more than 50%, and then finally the body literally just falls off its spondylooptost. Here, these are compressive extension injuries, so this is where the posterior elements are now going to be cracked, and sort of variations of that. I don't want to dwell into that too much. This is a very nice classification system from Alex Vaccaro's group. This is old, it's 2007, but really the one thing that it has done is that there's a lot of inter-user reliability. And when we look at any sort of system that is used to now classify things, the most important thing is we should be able to talk to each other in that same way. So if one looks at this, and it starts off with the morphology of the body, so you have a body that's normal, you have a body that may have a compression, but it's not burst, next it's a burst, lastly there's a distraction, and there are points that are given to those. A rule of thumb is once your scoring system gets 4 points and beyond, those are patients that need to have surgery. Less than 4 points, those are patients that can be managed non-operatively. Okay? That's just various pictures of compressions, bursts, distractions, and various rotations and translations. This is pretty much the most commonly used one. It's easy. There are wonderful little PDFs that you can download. You can put them on your phone, and they're all on the AO spine group. And I'm not going to go through this in too much detail, but the A's are really compressional injuries. So these are flexion injuries. The B's are extension injuries, and C's are going to be translations. And then they've added on various facet injuries, and those are the F's that we see there. Okay. And then just a nice algorithm of how to go through this. This is all on their website. Just go to AO and download these things. Okay, so when it comes to burst fractures, majority of burst fractures are going to be unstable injuries. And the issue with that is those bits of bone, especially on the lower part of that body, that get pushed back in towards the spinal canal. So those are some of the things that we're going to really be worried about. And many of them are going to happen when we're in flexion and getting that compression down on that body. Okay? So like we had heard, that fellow that dives into the pool on his head and Lexus, or somebody, Now, with these burst injuries, if one does an MR, up to 50% of them will also have an injury to the posterior ligamentous structures just during that distraction at the back. So these are generally very unstable injuries. Okay, patients will often come in quadriplegic with these, and if not quadriplegic, these are some of the syndromes that we may find. So in sort of the older population, and I think the central cord syndrome, these are probably the most common syndromes because of our aging population. It's that old person that's myelopathic, falls, hits their forehead, has a hyperextension sort of injury, and now they come in with this central cord injury. There's anterior cord syndromes, which really have the worst prognosis, and it's even worse if you have an anterior spinal artery that's been damaged. Posterior cord syndromes quite rare, and then there's Brown-Séquard, which have a very good prognosis, but we often don't see them in trauma. We will see them with sort of penetrating knife-type wounds. Where I was before in Cape Town, this was probably 1 or 2 a night. A lot of gang violence, a lot of shootings, a lot of stabs, people being stabbed. This is a simple thing. This is stuff that you all know. So the major tracts that we look at would be the spinothalamic tracts, the ventral. We have these corticospinal tracts in the dorsal columns here. depending on the injury pattern that we have. The anterior cord syndrome will take out all of this, so you have bilateral loss of motor pain and temperature sensation, and you will have intact proprioception because the posterior or those dorsal columns are intact. In a central cord injury, we have this sort of picture, so you have loss in the upper limbs more than in the lower limbs, and that's because of the topographical representation of how the corticospinal tract is. And the most important thing is sort of sensation. So if you have patients that have got sensation, then that's a very, very good sign, because as the perfusion around the spinothalamic sort of gets better, the corticospinal tract that's also at the same distance away from the core will also start to improve. So that's why you see a stepwise improvement of the structures that are further out going in towards the hands. Now, treatment of these injuries. So with mild cervical compressional fractures without any neurological deficits or any anterior compression on the cord, these are patients that can often be managed in a rigid sort of collar for up to 6 to 12 weeks. The issue is this is compliance. Patients don't keep those collars on. They will keep it on for 2 days, and after that, it's lost. Okay? There is a mention here on halo bracing. Now, how many of you have put on a halo? None. Have you ever seen it? Yes. 1, 2, 3. They're not common. They're hard to get. Okay? And with hot weather like this, just think about walking around with a sheepskin halo on. It's not going to last long. Okay? So halos are great, but we have issues with compliance and just trying to get those. Now, if the disc and the ligaments are intact, and this is seen when one does an MR, then there is an option to sort of halo brace. Like I said, halos have compliance issues, they're hard to get. The alternative is just go in and fix them. It's quick, it's easy, patients get up, out and faster and don't have to walk around looking like an alien. Now, when it comes to, I'd just like to quickly go through this algorithm here, and this is one of the sort of things I'd really like you to focus on. It's rather small, so I'll just read it for the ones in the back there. So this is an algorithm of the management of unstable, reduced fractures of the subaxial spine. So you have an unstable, reduced injury. The next question one asks, and this is often when you've now got your MR, is there anterior neural compression? Do you have a disc sitting there in the front that's compressing on the cord? If the answer is no, then do you have posterior ligamentous disruption? If the answer to that is no, so the front is fine and the back is fine, and if you wanted to just stabilize them after the reduction, then do an ACDF. If the front is fine, but the back is torn, then just fix them from the back. Let's move on to the right arm of this. You have anterior neural compression. Is the posterior elements disrupted? No. Just fix them from the front. If you've got anterior neural compression and the back is torn, these are patients that may require 360 surgery. So fix from the front and then screws in from the back. Okay? The take-home messages are really some of the the WFNS consensus statements that essentially have all been published, like we had been mentioned, we were told, and we'll just go through these quickly. So in the majority of acute injuries, so that's in less than 3 days, with locked facets, anterior cervical surgical techniques are sufficient to manage most of those patients. So it's really going to be your ACDFs. In chronic locked facets, these are patients that have been locked for over 2 weeks. It's very hard to reduce them just from the front. So these are patients you often need to come in from the back. And when you do come in from the back, I mean, in my very limited experience, and I really don't have the experience that some of our other speakers have, I've found it very hard from essentially a posterior approach to try and bring those facets back. So what I end up doing is I nibble the superior articular process of essentially the one below to try and get that back. And once that's done, you've got to fuse them. Okay. All locked facets should be reduced as fast as possible. That goes without saying, and you should have surgery done, especially on the ones that are neurologically intact, as soon as possible. Okay. The SLX system, very, very good system. In a nutshell, less than 4, you can manage them non-operatively. Beyond 4 points, you're going to theatre. Okay. So surgery is indicated for a progressive neurological deficit. That's quite obvious. Or stable incomplete deficits with significant spinal cord compromise. And in most situations, anterior surgeries are recommended for significant anterior column injury. Okay, that makes sense. An additional posterior surgery should be a thought for patients who have got multi-level corpectomies in the front to just stabilize them from the back. So the 360 that we spoke about. And in management of locked facets, if a posterior approach is done, get a pre-op. You must have a pre-op MR just to make sure that you don't have a piece of disc there that's come back. Like I said, it's got to be done after the reduction, because if you do it pre-reduction, you might reduce the body, but now you have a disc that's come out that you will miss. Okay, that's all I have to say for now.
Okay, I have a case presentation on upper cervical trauma. As I said, the craniovertebral injuries occur in 10 to 30% on all cervical spine trauma and are potentially lethal. The unique anatomy of the craniovertebral junction and the typical mechanism of injury yield a predictable variety of injury, of a traumatic ligamentous injury and bony injury or mixed lesion, and the management, surgical management of this injury remain challenging. The case I present is about a 35-year-old man was admitting to our hospital after a traffic accident. He denied loss of consciousness and reported neck pain with limitation of the neck motion. He had no neurological deficit. The CT scan showed a complex atlas fracture, Jefferson type 4, with bilateral fracture of the anterior and posterior arc of C1, fracture of the right lateral mass of C1, displacement of lateral mass over than 7 mm, rupture of the transverse ligament, and a distance between the den and C1 anterior arc more than 3 mm. The lesion was considered as unstable, and a craniocervical fixation was considered as suitable treatment. The surgical procedure was a posterior approach with exposure of the occipital bone and C1 and C2 vertebra. An occipital plate was fixed with 4 screws just below the superior nuchal line, and the screws was inserted point at the middle of the lateral mass, just below the C1 posterior arc lateral aspect, after drilling a small hole. For C2, fixation, 2 polyaxial screw was inserted in the pars and iliac bone graft was added at the end to achieve a good fusion. The immediate post-operative notice, no neurological complication, reduction of the pain, and X-ray control was satisfactory, and a rigid collar was remained for 4 months. However, 2 days later, the patient presents an infection complication with fever, neck pain, suppuration of the cervical site, and the bacteriological examination isolated a multi-resistant Escherichia coli. The patient went for surgery debridement associated with appropriate antibiotic for 4 weeks. The implants were not removed, and the patient recovered and was discharged from hospital with a rigid collar. 3 months later, he had again he had neck pain with new suppuration of the chirurgical site. We noticed an occipital extrusion through the skin, and the CT scan confirmed infection and showed the occipito-cervical implant failure. The patient went for surgery again. The implant was removed with debridement and made conservative treatment. The first operative course after 2 years follow-up remained a good recovery. The CT control showed a consolidation of the lesion and no complaint with neck pain, but less motion of the neck. This is the case I want to present. Thank you for your attention.
So this is my content. So about the thoracolumbar fractures, there we have some problems about the mechanical problems. So we have compression, we have dislocation and instability, and we have some neurological deficit. And if we can solve them, we have to prevent it, and if we can do it, we can recover them. So in the follow-up, we may have deformity and pain. So there are 3 types of classification system. The first one is Dennis classification, as you know. The second one is AO classification system. AO is a good classification system. We have TRIX classification, and it has morphology about we have idea about the mechanism of the injury. We have neurological statue, and we have the posterior complex problem there. So this is the AO classification system. Please try to learn it at this session. A is compression, B is distraction, and C is the translation. And if you look close to it, and we also have modifiers for it, please look at A1. It's compression, it's wedge compression fractures. A2 is split. We have fracture at both end plates. In A3 we have only fracture at one side. In A4 we have fracture in bilateral end plates here. So please take care at B1. It's chance fracture. Maybe you will see it in an exam. They may ask you it. In B2, it's you again have posterior tension band disruption, and B3 is the disruption, the hyperextension injury mechanisms, and we see especially in ankylosing spondylitis cases. And type C Please take care, it's translation. So, I don't know, I never summarized this classification system, but please take a photograph of that. There are lots of applications on the phones, and if you download this application, you can easily classify the AO and the text classifications here. So the application is very easy. Just you select the AO classification here, then the system asks you the displacement tension band, or you have just select them and it says that it's type B3. So if you follow up the charts that AO has published, you will see its works. So text classification is a good classification system because it says that you have to operate that patient or not. So these three subtitles are very important. You again choose it from the application, and just in a few minutes you will learn if the patient needs a surgery or not. So this is the application again. You just select if the patient has a ligamental complex injury or has a deficit, and you just choose the morphology of the fracture. Then it says 8. If the patient's score is greater than 5, you have to operate that patient. So the treatments are the treatments depend on to fracture, to surgeon, and according to patient. The fracture depends on the level of the fracture. The junctions are very important. So you see how many surgeon cents are inside the patient. This was a thoracolumbar junction fracture here. Pulmonary chest doctor, surgeon was there, and general surgeon was there. So if you have the team, you can do surgeries, combined surgeries like that. And patient-dependent factors are additional injuries, medical comorbidities, and osteoporosis. And surgical decision-making is you have the anterior and posterior approach. If you do it from anterior, you can directly decompress it. You can add an anterior support then, and you will do a short segment surgery. And if you do it from posterior, it's indirect decompression. The levels are long, but it's more stronger. And we are familiar with this approach. This is a case example. This patient was 79 years old, has ankylosing spondylitis, has a car accident, has back pain. You see there is a disc rupture here coming to the posterior part. So then you see the images. This is the 3D. If you look at it, and if you apply the application, the score is 6. So we need surgery, and what we have done here, this was a special case. Ankylosing spondylitis cases may need longer lever arms, so you have to increase the segments here. So the thing that we have done here was we put intermediate screws. This intermediate screws means you insert screws also into the fractured vertebra here, and we used double rows here. So take-home messages are: AO is a good classification system to determine the fractures. Use text classification for surgery. If it's greater than 5, you need surgery. You have many options, but the main message here is do what you can do best. And I'd like to invite you to the Congress of Middle East Spine Society that's going to be held in September in Istanbul. This was my presentation, and this will be my case. So I need a microphone. Someone is talking here.
Yes.
Yes. So, 41 years old female, car accident, back pain, non-neurological deficit. So, colleagues, you form. Yes, type what?
You can use that
Okay.
because the pointer will not.
Can you do a
Change.
full screen?
Yes, you can change here.
Dear friends, I will talk about acute management of spinal cord injuries. This is initially planned by, presented by Dr. Salman Sharif, and I will replace him. I think if there is no spinal cord injury, spinal trauma would be fun. But this patient has a lot of challenge for us, and the outcomes is not good. So this is the hardest part. When we look at pathophysiology, there is two types of injury to the spinal cord. One of them is primary injury. It means results from an initial traumatic force applied to the spinal cord. It is already done, and we cannot anything about that. We can do nothing. The trauma is absorbed by the spinal cord, and deficit is there, and we cannot reverse it surgically. But there is other traumas ongoing. We call it secondary injury. Process following primary injury, including loss of autoregulation, disruption of the microcirculation, cord edema, and ischemia. These are all preventable. If you manage good, the patient, you will diminish the neurologic deficit of the patient. So our goal, our mission here is to prevent secondary injury. So acute care of spinal cord injury patient aims to prevent secondary injury due to undetected instability. More instability can be done if you cannot detect it. And ongoing compression, hypotension due to vascular collapse, and other reasons of secondary injury like bowel bladder distension, etc. They all cause more harm than the initial one. Initial management includes some steps, starts with evaluation and if necessary resuscitation. Let's look at them. This is a known maneuver. We all know that kind of things. We need to be very careful in that patients. The main guy fix the cervical spine, and others has to move the body between the tables, and the examination should be done in a proper place with that maneuver. Principles of evaluation is to assess first vital status like tension, arterial tension, and breathing, and spinal and other skeletal injuries should be detected. Neurological injury should be documented, and we need to establish a treatment priority. Our steps are here. We need to first look at is ABC, airway breathing circulation is maintained. This is the most important and urgent one. If no one can live without breathing, airway is the first one, and then circulation follows. After that, we need to complete our physical examination. We need to look at the patient physically, abrasion, laceration, deformities all over the world, all over the body. Palpation of the localized pain for spine. And neurological examination should include all domains of the neurological examination. And then radiological evaluation follows. we can classify spinal cord injury basically complete or incomplete. Complete means there is no motor or sensory function causal to the level of injury. That means at that level, below that level, there is no sensation and motor function and no sphincteric function, no sacral sparing, that means some contraction in the anus. That means complete cord injury. And after 24 hours of that kind of clinical picture, you can say that this is irreversible. In the first day, there may be some changes due to the hypotension. If you can correct it, some functions may return, but after 24 hours of complete injury means nothing left to save. And incomplete injury means if some motor or sensory function below the affected area is preserved, this is incomplete injury. We use some classification systems. ASIA is the most used one. ASIA A means no motor, sensory or sacral sparing, that means complete lesion. B, incomplete. C, incomplete and 50% of the muscles less than grade 3 muscle power. D means more than 50% of muscles grade 3 can raise arms or legs. And normal function means E. And we have some specific syndromes, as you know. We need to carefully study all of them. They show some distinct neurological findings and distinct prognosis patterns and distinct treatments. We need to name the syndrome's name if it is incomplete. Then we order imaging studies. Plain X-ray is the first line. CT scan MRI is other tools. Missed injury is not very seldom. Rate is as high as more than 30%, and that can have very severe consequences to patient and also to you because of medical legal reasons. So therefore must be presumed a spinal injury is there until it is excluded. CT scan X-ray depicts fracture or displacement where a CT provides better visualization and the extent and displacement of the fracture. The CT scan should include sagittal reconstruction for a better viewing. Magnetic resonance imaging is good for soft tissue, ligamentous disruption, the canal, disc herniation, cord edema, hematoma, and contusion of cord itself. In management, step by step, if we need to give such a formula, airway is the first step. Is it open? And if it is open, breathing is enough. Is it sufficient? If it is not, you need to make a intubation or just nasal channel oxygenation. And then circulation comes into place. Careful hydration is important. Too much fluid is not good because of abnormal hemodynamics. Pulmonary edema can occur, so you need to restrict and monitor the fluid intake. Atropine and vasopressors may be necessary to correct bradycardia and hypotension, and nasogastric tube is necessary because most of the patients with neurological deficit has autonomic findings also, like paralytic ileus. It prevents vomiting, aspiration, and decompressed abdomen, which helps to better breathing. And then we need urinary catheter to prevent distension from urinary retention, also to follow up neurological status. And temperature regulation is important. Patient may have loss of temperature control due to vasomotor paralysis. electroregulation may be disturbed. Hypovolemia and hypotension cause increased plasma aldosterone, which may lead to hypokalemia. And DVT prophylaxis in the long term very important in that patients. Neurologic shock means decreased systemic vascular resistance. It is different than the vascular shock. 25% of the cervical spinal cord injury patient experience some component of the neurogenic shock. And maintenance of a mean arterial pressure of 85 millimeter or greater for the first 7 days is found to be beneficial. Dopamine, norepinephrine, and epinephrine are common first-line agents for treatment of vascular shock. Maybe it should be rewarded. This kind of vasopressors correct vascular shock. Neurogenic shock means complete absence of the neurological functions in the first place. You know, when you when you experience a cord section, patient initially is at the shock, neurogenic shock. All the deep tendon reflexes are absent, but then spasticity occurs by time, after weeks or months. But in the first place, you may experience an absence of all the motor function and reflexes also. And these are the some recommendation of the WFNS Committee. Only they say that only 40% of patients with lesions above C4 are successfully extubated. So early tracheostomy within 10 days in these patients leads to a shorter ECS stay and reduction in the length of time of mechanical ventilation. And predictors of a need for tracheostomy, Asia A complete lesion patients, extent of the lesion, smoking status, and previous lung disease, all are predictors of a need for a tracheostomy in the first place. Managing the airway in the CSI, video laryngoscopy is an alternative to conventional direct laryngoscopy to keep the cervical spine intact. And fiber optic laryngoscope is beneficial during laryngoscopy in that kind of patients. If you cannot intubate and cannot ventilate the patient, sometimes emergency tracheostomy may be necessary. Pharmacologic treatment in spinal cord injury is very debatable, and so far there is no known effective agent to correct spinal cord injury. Their role has been proven controversial, and many ongoing trials of their role has negative effect in treatment of spinal cord injury. For example, methylprednisolone, once used frequently, is found today administration of methylprednisolone for the treatment of acute spinal cord injury is not recommended, not approved by the FDA, and there is no class 1 or class 2 medical evidence. And some class 1, 2, and 3 evidence conversely suggests that high-dose steroids are associated with harmful effects, including death. So, is there any use of methylprednisolone today? Who uses methylprednisolone in a severely injured patient, neurological deficit today? Who use? Okay. So we have no proof about that. Conversely, we have negative results about their harmful effect. Maybe only one indication should be, this is an expert opinion, expert is Michael Failing, so it's maybe should be considered. In selected young patients with acute severe cervical spinal cord injury, if you catch that patient in the first 24 hours. In that patient with a severe cervical cord injury, in a young patient, you may apply it according to that expert. Other than that, no need to use. And timing surgery is important. More and more studies show that early surgery, early decompression in the first 20 hours is beneficial. And it's shown that at the 6 months post-operatively, early surgery decompression was associated with 2.8-fold increase out of 2-grade Asia impairment scale improvement with no difference in acute complications. So if you can operate the patient, if you can decompress the patient in the first 20 hours, it is worthwhile. But some others say that surgery is delayed beyond 6 hours, your success rate is diminished. So the golden hours is 6 hours, I think, which is very difficult to catch the patient in that thing. But at least you can try it, do it in the first 24 hours. So the take-home message for this presentation is acute management of spinal cord injury includes immobilization, emergency airway breathing circulation maintenance, and complete physical and radiological evaluation. Hypotension should be prevented and corrected. Medical treatment is debatable. Methylprednisolone is not recommended today. Early surgical decompression, especially in the first 6 hours, is beneficial. Thank you for your attention.
So, we prepared posterior surgery first because the compression at the spinal cord was very severe there. The thing that we have done here was, first of all, we applied laminectomy. We put the screws. Then we changed the position to anterior. We made a corpectomy at 2 levels. Because, look, there is something here at this level. Can you see it? Okay. During the surgery, we also seen that there was some distraction at the upper part of the vertebral body here. We make 2-level corpectomy here. We put an iliac graft, an anterior plate. Then we change the position to prone position again. Yes?
I did not understand the surgical plan, what you were saying.
So, the plan was that if you go directly from anterior, okay, the compression at the spinal cord is severe, okay, you can increase the neurological deficit. Because of that, to get more space, you make a laminectomy first. So if the tumor passes there, compresses there, you have space at the posterior part, okay? Then having the laminectomy there, you have more space. If you go directly to a very stenosis segment there, you may have neurological deficit, okay? Then you have space, then you again put the screws from posterior, okay? Then you change to anterior, you make a corpectomy, you put the graft. Then to make a good cervical lordosis, you again turn to posterior and insert the rose, okay? And this was after the surgery. So, this was anterior, posterior, posterior surgery. Can I get the microphone?
Okay. Thank you very much. Thank you.
And what was the pathology?
The pathology was, it was bladder tumor metastasis and radiotherapy and chemotherapy. Thank you.
Full screen.
Just a minute.
This talk again initially given by Dr. Zileli. I will replace him. Definition of is pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So very complicated description because the issue is very tough indeed. It's a subjective feeling, and each patient learns the application of the word, pain word, through experience related to the injury in early life. So everyone describe other, use other terms to describe their suffering. Everyone use other meanings of the pain. The problem is low back pain is a chronic, benign pain syndrome. It is not life-threatening, but there is high incidence and prevalence, and it has great impact on patients' and families' life. And medically, our classification system is not clear. Specific cases are much less. We cannot differentiate the main reasons when we say non-specific. And non-specific could be acute, subacute, or chronic. Management shows also very large variations between the disciplines. A physical therapist, an orthopedic surgeon, a neurosurgeon, and algology specialist, very different ways for the low back pain. What is the source of the pain? Let's look at from that angle. Source of the pain is one of them: discs, muscles, joints, facet or sacroiliac joint, ligaments, and nerves. All the tissues in the area can produce pain. And these are the facts. Identifying the source of the source is more possible with history taking and examination, not radiology. When you make an MRI and see some degenerative changes, you almost always cannot say this lesion is the reason for the symptoms. So there is no correlation between the symptoms and radiological findings. In almost 90% of the cases, source is not clear and diagnosis is just a rough mechanical back pain. Radiology and clinic rarely correspond to each other, like I say, and 25 of the adults have disc herniation and spondylolysis, spinal stenosis on MRI without any pain, any symptom. If we get a MRI for each of us in that class, we will see a lot of disc herniations, even some spondylolisthesis, some canal stenosis without symptoms, with or without. And pain of the spinal origin. If back pain more than leg pain, there may be some possibilities. That could be mechanical low back pain, discogenic pain, facet pain, and myofascial pain. All of them has some different clinical characteristics to help you how to differentiate them. For example, for mechanical low back pain, if the reason is not clear, there are always deconditioning, poor muscle recruitment, emotional stress, and you see degeneration, aging-related changes. Patients generally have a bad posture and soft tissue pathologies. For discogenic pain, patients may describe some band-like pain around the belly by lumbar flexion. It could be unilateral. It could radiate to the buttock, worsened by extension or side bending and sometimes flexion. And morning stiffness, pain with coughing, more pain during sitting or standing are observed. If leg pain is more than back pain, I think our job is much more easier. The possibilities are lumbar disc herniation. It is presented as mostly unilateral calf, buttock or thick pain, discomfort or weakness. We all know the neurological findings for specific disc levels. The pain can distributed as a sciatalgic pain or femorrhagic pain to anterior to the hip. The reason could be a sacroiliac joint pain. In that case, pain looks like similar, but generally not radiate to the level of knee. Does not radiate there. And for neurological clarification, symptoms are again bilateral or unilateral calf, buttock, thick discomfort, pain or weakness, and it is precipitated by the walking and prolonged standing, and is relieved by changing position and especially flexion or kneeling. There is some specific reasons. It is very easy when you see that kind of findings on X-rays, MRIs. You can easily identify the reason of the pain. These are spondylolisthesis, spondylolisthesis, osteoporotic compression fracture, of course cancer and low back pain, spinal infection and rheumatoid disease. Mechanical low back pain is generally related by poor muscles. For example, you see the ropes here, muscles has a tension to fix the spine, but here muscles has no attaching function to spine to the pelvis. And wrong postures, wrong sitting postures is very common at modern age, are reason for low back pain. Myofascial pains originated from muscles. Generally, they show some trigger points for each of the group of the muscles. They have a typical place for each of the muscles, and they have some atlas, clinical atlases to show that. Discogenic pain is caused by the disc degradation, and it is called as isolated disc resorption without disc herniation. Sometimes it may cause back pain and sometimes leg pain. These are another appearance of the disc pathology. We call it internal disc rupture. This is some ruptures in the annular layer inside, and it causes back pain without disc herniation. Excessive loading, one of the reasons. Yes. Okay. We can classify the back pain in different ways. We can call it nociceptive pain. It's originated by somatic tissues, skin, deep muscles, bones, joints, or neural tissues. We call it neuropathic pain. The pain distribution and its properties are different. When we order testing pain, if you get a good history taking and there is no red flags, most of the patients do not need further investigations and further therapy also. What are the red flags? Red flags means some findings to show very dangerous disease behind. These are new onset of pain in patient with known previous malignancy, weight loss, loss of appetite, fevers accompany. If new onset of pain after age of 60, it's another red flag. If serious neurological findings accompanies, like caudate findings, and if pain intensity did not increase after 4 weeks, if pain does not decrease during rest, during night, pain during night is a sign for red flag. In conclusion, the source of the back pain are multiple. There may be more than one source in certain patients. The source of back pain can be best learned by identified by a good history taking and examination of the patient rather than radiology. The value of radiology is very small in identifying the etiology of the back pain. Most common reasons of the back pain is weak muscles, lack of exercise, wrong posture. That means mechanical low back pain, and most of the patients are like that. Myofascial pain, discogenic pain, sacroiliac joint pain, and facet pain are the other common reasons of the pain. Thank you for your attention.
The next topic is about lumbar and thoracic spinal stenosis by Dr. Ono Yaman.
We all know about lumbar and thoracic spinal stenosis. I'm going to make a little summary about it. So we're going to learn how to define stenosis and the etiopathogenesis of spinal stenosis and how to diagnose it and how we have to treat it. So we know we have central stenosis and also lateral stenosis. We have cervical, thoracic, lumbar, spinal stenosis. So everything is starting with this degeneration. I think, did you ask at the beginning or in Jumhur wheelchair presentation? So there is a cascade there, okay? There is a disc degeneration, it collapsed the disc, then it's narrowed the foramina. The facet gets hypertrophic and slowly it's progressive. So this is a good schema. Everything is starting with disc degeneration. Then we have stenosis here. Then the patient may appear instability there. Then that instability may cause kyphosis or scoliosis, and it progresses and it causes pain. Because of the pain, patient is not moving. Because of not moving, the muscles get weak. There is a cascade there. So allostasis means one vertebra is getting lateral to the other vertebra. It's because, again, with asymmetric disc degeneration, ligamentous relaxation, facet degeneration, and all of them may cause and coronal and also sagittal plane deformity. So we may also see thoracic spinal stenosis. It's very rare, but we see it. So the symptoms of spinal stenosis are back pain, radicular pain, and neurogenic claudication. The cause of the neurogenic claudication is prolonged compression. It decreases the cerebrospinal fluid supply. It makes changes in the microvascular structures. The venous get congested, and it causes root nutrition. It decreases. So there is a difference between neurogenic claudication and vascular claudication. The patient has pain in the buttocks. The pain relieves in 5 or 10 minutes, but in vascular claudication the relief time is fast. The patient may have hypoesthesia, the pulses are fine, and there is no trophic changes in neurogenic claudication. So if you look at the CTs, you may see the decrease of the diameter in AP and transverse diameter. You may see the hypertrophy of the facet joints there. So the natural history of spinal stenosis, most of them are same and some of them are progressing. So what can we do with conservative treatment? You can recommend loss of weight, you can recommend brace, you can recommend medications. You can also recommend physical treatment and epidural injection. And if these recommendation does not work, you have to recommend surgery. What are the choices? The first one is just laminectomy, bilateral hemilaminectomy, or you can use unilateral approach with bilateral decompression. Laminectomy has a good success, but you may lose blood loss and hospital stay may get longer. Because of that, unilateral approach with bilateral decompression is a good way. Just you go from one side and you decompress the other side. It has less instability, less blood loss, short hospital stay, and you can use it in multiple levels. For fusion indications, if there is an instability, if you remove more than 50% of the facet, and if it's progress, you have to fuse that patient. The complications are dural tear, nerve root injury, cauda syndrome, infection, and epidural hematoma. For the take-home messages, disc degeneration starts everything in lumbar and also the thoracic spinal stenosis. You have to do the surgery if the conservative treatment does not work and if you have neurological deficit. And unilateral approach with bilateral decompression is a good option. And please do what you can do best. And I have a presentation of Professor Zilali here. Cumhur abi devam ediyorum bilgisayarı değiştirmek için. So the patient was 64 years old, has neurogenic dedication in 100 meters, has no neurological deficit, no back pain. If you look at the MRIs, there are multiple level spinal stenosis here. So Zilali preferred unilateral approach with bilateral decompression here. These are the pre-op and post-operative view of that patient, the axial views. So, as I mentioned in my presentation, unilateral and bilateral approach with bilateral decompression has less invasive and less bleeding surgery. So the technique is that you remove one side lamina, you go through the interspinous ligament, you try to see the other part of the spinal cord. In many cases, you can decompress that levels very good. So during the surgery, you have to bend the table to the opposite side, and if you prepare the position of the microscope, you can see it opposite directly to the other side. So Zilali is using tube-guided surgery. He inserted a key wire then, and then put the dilatators there, and he fixes it like this part here. Then he used endoscope during the surgery. So if a patient does not have any back pain, decompression alone is fine. But if the patient has instability, or if the other conservative treatment does not work, you have to make a decompression plus a fusion surgery. Thank you so much. Any question? Will you get it? Okay. Thank you.
Okay, discussion.
Yes, it's mine. Of lumbar disc herniation, one of the most frequent indication for surgery or treatment. It comes from Dr. Salman. No, not that one. Salman. Yeah.
6.
Yes. The case is sent by Dr. Örtel from Germany, and Salman prepared it to show you. Then I show you. No, this is not mine. Have you opened it here? Open it here. I'll change it. Here. Yes. I will show the case, and I will try to get your opinions about how to manage it and what is your diagnosis, what is your differential diagnosis. This is 25 years old female with no known comorbidity, presented with lower back pain radiating to the right lower limb radiation till the toe. It has the pain is continuous for since last 2 years, increased in the last 2 months. VIS is overall VIS is 7 up to 10, and leg pain was more than back pain. In examination, there is 4 of great muscle strength at the right side of external hallucis longus. So just toe extension is disturbed, 4 of the 5, and there is a straight leg rising finding at the 30 degrees at the right side and 60 degrees on the left side. Reflexes was normal and no sensory deficit. Patient is ordered an MRI. Here the MRI findings. This is T2, and this is the axial cuts. The upper one is, I think, from 3-4, and lower one is from the 4-5. So let's discuss what is your diagnosis, what could be another thing, and what is your neurological localization, which root is affected, what are your treatment options, and if opt for surgery, what kind of surgical techniques would you use? Any idea about that kind of patient? What is the reason for leg and back pain? What do we see here? There is black disc in the 4-5 level and discal bulging, and there is slight disc space height diminished at the L3-4, but disc intensity is good. And then maybe we need to notice another thing. There is fat tissue inside the canal. That could be sometimes symptomatic, epidural lipomatosis, but in that case I think it is not. This is fat. So the cerebrospinal fluid is cut here. Is there any possibility that patient could have another problem? Disc herniation. Yeah, this is probably the reason for the pain is that, but this is also a major reason for failed back surgery. Patient may have another problem, and there may be an innocent radiological finding, not creating symptoms, and another problem creates symptoms, and you operate and patient does not get better. So we need to think about what are the other reasons of the back and leg pain, especially leg pain. Do you have any idea about extraspinal reasons? For example, sacroiliac joint can mimic that kind of thing. Yes, could be. What about piriformis syndrome? This is another reason. Squeezing the sciatic nerve between the muscles inside the buttock is another reason for leg pain. These are much less possibilities here because we have some findings to prove us or make us think that reason for the pain come from the disc, because she has straight leg rising sign. This is a very indeed good sign to show pathology is there. So after that careful consideration, we at least thought that the reason for the pain is disc herniation. And now, which root is affected? L5 root. This is 4-5 disc herniation. Traversing root is 5. And what are treatment options? Anyone suggesting conservative therapy? It could be, but patient has pain for 2 years, and at the last 2 months it increased too much.
So the pain is worsening?
Mm-hmm. Yeah, at the last 2 weeks it is worsening, 2 months. Yeah. I think no point to wait too much. We need to apply something. What is that? Just direct surgery or epidural injection? Okay. What kind of epidural injection? Interlaminar or foraminal? Foraminal injection. Foraminal injection is better because it reaches to the anterior dura, and the patient has also some canal narrowing. Interlaminar is not too safe. So it may be tried. Patient may get better for a while, for a couple of weeks or months, but then she came back again with the same symptoms after 3 months. Can you apply another injection? Some schools apply 3 injections with intervals, 1 or 2 weeks intervals, 3 injections. Some schools just apply 1 injection. So this is a good option if patient does not get an operation, or patient has a premorbid, it's difficult to operate. Epidural injection is a good tool to try for us. And your surgical technique. These are the options. Open laminectomy, laminectomy and discectomy, microscopic discectomy, endoscopic discectomy. Yes?
Microscopic discectomy.
Why? Why you choose that?
Because this is we have a microscope and in our department,
Okay.
but we have not endoscopic or laminectomy is
Okay.
more expensive.
Okay, you have that tool. So it works in your hand, so it's very feasible and logical to opt for a microsurgical discectomy. How do you apply your technique? You remove all of the disc?
No, only the compressive part of disc and
Compressing part of the disc.
yes.
Probably there is no free fragment. right? From the view, you see that there is a bulging. So you will see a intact annulus. The problem is here probably the lateral recess stenosis. In some of my cases, I tried that and it worked. I just removed here, make a decompression posteriorly. I checked the disc. If the annulus is severely softened, and there is some movement when you press your dissector, there may be some free fragments in between the layers of annulus. It could be worthwhile to remove it. But even for that, you disrupt the annulus, right? And you have risk of disc recurrence. So all the disc surgeries are disruptive surgeries. The narrow spinal stenosis is not like that. You just remove the pathology, and you don't disrupt anything, just removing the pathological tissue. But here, you remove the disc, you open up the annulus, and you may have some subsequent problems with this recurrence. So if the disc is very tough and solid, I will not touch the disc. I will just decompress the lateral recess and leave it like that. Our goal is to make a nerve root decompression, not discectomy. Yeah, that's it. Any questions or any idea about that important subject? I think disc herniation. No. Thank you.
Excuse me?
Yes, please.
Yeah. So regarding the treatment plan, this patient had been experiencing pain for 2 years, and she has been managed conservatively before even coming to you. And now she said 2 weeks, the pain is worsening.
2 months.
2 months.
Yes.
The pain is worsening. Okay. So
Yeah.
I was thinking, why not? As you know already that if even you do the sterile management, the patient will definitely come back. Why can't you just proceed with surgery?
In the first place,
Yeah.
yeah, some of us thought like that. It's an optional also. You don't have to try an epidural injection. There's an option. It's more related patient's preference.
Because the issue with epidural steroids as well, if you do it 2 or 3 times, that is going to thin the dura. So if you are going to do surgery, you are going to have a dura tear. The likelihood of dura tear is high.
Mm-hmm.
Thank you.
Yeah, this is a complication. But injection has one more advantage for that kind of patients. I remember a patient, a woman, there's a clear disc herniation compressing the root and some leg symptoms. But I didn't like the patient and her behaviors about she exaggerated this patient. And I made an injection. She didn't get better. Although I see the contrast is there, all the root is, and she didn't get better. And I learned that she washed his hands until his skin is disrupted, some sort of psychiatric problem, and I refused to operate. So this is a good point when you make your patient selection. It may save you. Yes.
Beyond this stage, we have one patient with only small intraspongial herniation.
Small nodule?
Yes,
Mm-hmm.
but with refractory pain.
Refractory? Refractory.
Lower back pain.
Refractory pain. Okay.
And we try to use steroid,
Mm-hmm.
but
there are no solution for the pain. What is the option?
Acute painful small nodule, right? Yes, it creates a lot of back pain, sometimes radiating to the root. There is some edema around the, and there is end plate fracture around the disc herniation. This is disc herniation. Small nodule is a disc herniation inside the bone. I generally apply discography and that kind of discography. I go inside the disc from the cambin. I apply local anesthetic and small dose of corticosteroid. And in the procedure, patient experience too much pain. That's a good thing. This, because it's prove you that source of the pain is this disc, and patients are generally get better with that. It's a good option. Intradiscal injection. Thank you.
Okay, thank you. We stop the session now. Dr. Mirza has a problem of visa, and we do his lecture when he's back. So we can go for lunch. We are 1 hour, and we're back at